I know some of you, and so I see some psychologists, dentists. Can you give me a range of the training of the other people who are here in the room? Sociologist.
Nurses.
Okay.
Social work.
Okay.
Physician.
What I'm going to be talking about today, I'm going to talk about pharmacologic management of behaviors in the nursing home. And you'll realize right away from the beginning of that talk that there's usually only a subset of individuals in nursing homes who need pharmacologic management of behavior. And those are typically demented individuals who have specific expressions of behavior which are either dangerous or intolerable. So most of my remarks are going to be confined to that population. And I'm going to try to put the use of neuroleptics in these patients into two contexts. The first is a clinical pharmacologic context so that you understand the rationale for using some of these drugs and the predictable side effects and how to intervene on side effects should they occur. And the second thing is I'd like to put it in a regulatory context because as well as many of you are aware, the nursing home environment is now intensely regulated, and specifically there are proposed policies that are extremely detailed governing the use of both chemical restraints and physical restraints. And in the original guidelines proposed by HCFA about 18 months ago now, which were subsequently revoked, chemical restraints were so liberally defined that any drug which had as an intended or unintended effect an alteration of the CNS was considered to be a chemical restraint, which meant that no antihistamines, virtually no drugs that had any potential CNS effects could be administered without informed written consent by the patient and or his legal representative. So those policies have been liberalized somewhat since they were pretty impractical, and it really ended up treating the administration of neuroleptic agents as something substantially different and distinct from all other forms of medical therapy, which in fact they are not. I want to say as a baseline that I favor, in almost all cases, refraining from using neuroleptics in elderly patients for a variety of reasons. The primary one of which is that they often do not work, and the second one of which is that they can produce significant toxicity. But I think there's a subset of patients in whom they're not only indicated, they are profoundly beneficial. And I think all of you have probably witnessed this. And so what I'd like to do is give you a framework for trying to assess when these drugs might in fact be indicated, and then a guide to how to select specific agents that you might want to prescribe. And there'll be a sprinkling of clinical pharmacology in there so you can understand the sort of pathophysiologic action of these drugs. I have to give you the caveat, though, that there's a lot known about the specific pharmacology of most of the neuroleptic type agents. There's also an even greater amount which is unknown. So I think our knowledge about these drugs is continually evolving, and what I tell you today is likely to change tomorrow and the day after that and the day after that. I think we've gotten much more sophisticated, but we aren't there yet with respect to these agents. As you are probably aware, the physician's role actually in managing behavior in the nursing home is relatively minimal. The physician has relatively little day-to-day contact with the patient. They spend relatively little time in trying to urge, coerce, or facilitate the patient's participation in his own care, and they spend almost no time in trying to decompress patient behaviors which may be troublesome or bothersome. And so the physician usually is put in the context of controlling behavior in the nursing home in response to the requests of other providers. And so my decision making is generally, Mr. Blank is doing so-and-so. Could we please have something to calm him down? That's a typical request that I would get over the telephone. And so what I would like to do is sort of change the paradigm of that response, of that request, which is not Mr. Blank is doing so-and-so, can I have something to calm him down, but rather Mr. Blank is doing so-and-so. Here are the things that we've tried so far. They have not worked. And now I think we're at the point where we're not going to be able to handle this person behaviorally anymore. If you look in the handout that you got, actually there's a very, very carefully thought out attempt on the basis of, that was done by Wayne Ray and Mike Lichtenstein to try to, number one, characterize the kind of behavior that the patient's having, and then develop specific behavioral strategies that will try to deal with that behavior apart from drugs. This originally, all this literature originally came from actually research regarding schizophrenia. Let me see. So I can then just turn this off when I want to, and then, okay. And I have a little trouble with disorientation using these things too. Is that focused? Okay. Now, most of the literature regarding use of these drugs in dementia, in fact, evolves from their use in schizophrenia. And most of our knowledge about the efficacy of these drugs in dementing syndromes evolves from their use in schizophrenic patients. Now, obviously, schizophrenic patients are an entirely different substrate than an older patient who's got a progressive degenerative dementia, which would be a typical patient in the nursing home. But in fact, most of you are probably familiar with the concept of positive symptoms of schizophrenia and negative symptoms of schizophrenia. The patient who has positive, that is, outward manifestations of behavior which are troublesome, delusions, and those can be fixed ideas about something that's happening in the environment that isn't reflected in your perception of reality. Hallucinations are pretty obviously. A formal thought disorder, a patient who cannot link thoughts together in any kind of coherent or tangible way. Totally bizarre behavior, which may be alarming or even potentially dangerous. And then disorganized thinking, somebody who's tangential and can't really think through something logically. Now, many of these, particularly the disorganized thinking, are a common concomitant of advanced dementia. They're part and parcel of that syndrome. And they're not something that you would expect to alter on the basis of drug administration. The primary things that you would expect to alter on the basis of drug administration would be delusions, hallucinations, and bizarre behavior. The negative symptoms of schizophrenia are some things that you typically see in patients with advanced degenerative dementias, particularly those who have sort of subcortical dementias. Sort of the poverty of speech, the sitting around, the withdrawn behavior, a resistance to care, a loss of interest in all things, and an unwillingness to participate in activities in the nursing home. And this is a very helpful model because, as it's turned out, the literature from schizophrenia has helped us understand that these positive symptoms commonly respond to drug therapy, or to some extent they respond to drug therapy. Negative symptoms rarely, if ever, respond to drug therapy for administration of neuroleptics. There are other people who have tried, in fact, stimulant drugs like methylphenidate or Ritalin to alleviate some of the negative symptoms of dementia, with actually some marginal success. But the neuroleptic agents themselves do not work for negative symptoms, and in fact they frequently will exacerbate negative symptoms. So that we're going to extend that now into treatment of neuroleptics in the nursing home. Got too many controls here. So these are, and I wanted to let you know that in the OBRA Act of 1987, which was in, can you focus that? I can't actually see whether it's focused or not. In the OBRA Act of 1987, which in fact is the primary act which regulates the use of neuroleptics in nursing homes, they were very clear cut. There's a list of things for which neuroleptics are indicated, and there's a list of things for which neuroleptics are not indicated. And your requirement as a care provider in the nursing home is to write down the indication for which you're giving the drug. I mean, that's the primary situation which you might find yourself in error. And you can see that schizophrenia, which is a clear-cut diagnosis, psychotic mood disorder, usually is an expression of mania or depression, and then a delusional disorder are the primary things that you would see in a nursing home. And they'll also allow for short-term treatment of hiccups. Also, there are several clinical trials which have looked at the use of neuroleptics for both the presence of positive symptoms and a functional deficit or paranoia. And there was a meta-analysis actually published in the JAGS about a year ago, which looked formally at this question. Do neuroleptics administered in the face of dementia with positive symptoms, are they effective for treatment? And the answer is a definite, we don't know. It looks as though the sedating neuroleptics are extremely effective in controlling agitation. And the most neuroleptics are extremely effective at controlling hallucination. The difficulty is that they do not improve cognition. In fact, they may cause worsening. They do not improve memory. In fact, they may cause worsening. They have little effect on wandering behavior or crying out behavior, except through the mechanism of sedation, knocking somebody out essentially until they're unable to exhibit undesirable behaviors. Neuroleptics are thought to potentially be indicated even though they act through the primary mechanism of sedation if the patient's verbal outbursts are so continuous and so bothersome that they're interfering with the function of the staff and with other people in the facility. And they're definitely indicated for behaviors in which there's direct danger to the patient himself or to others. I can think of perhaps one or two situations in my entire history of taking care of patients in nursing homes and geriatric situations in which behavior was actually a physical danger to the patient or others. So what I'd like to do then is talk to you a little about the pharmacology of these drugs. Now, most of these drugs they have multiple sites of neurotransmitter action. The hypothesis of why they work is that they produce a dopaminergic blockade in both D1 and D2 receptors. But in fact, most of these drugs have actions at multiple levels. They have both alpha-1 intrinsic Most of these drugs, in fact, have multiple effects. I can't ever do this.
I think we need to move the machine a little bit.
No, we don't need that. We'll just do this. Most of these drugs, in fact, have intrinsic alpha blocking agents. They have serotonergic effects, which cause sedation, and anticholinergic effects. Their intrinsic alpha blocking effects cause orthostatic hypotension, and their dopaminergic blockade action produces direct extrapyramidal effects. Now, as you're probably aware, dopamine tracks are in various locations in the brain. They're mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular, and I don't expect you to know that. The primary reason for showing you this slide is that you can see that these tracks innervate different structures and account for different functions. So the dopamine tract that's primarily mesolimbic really controls emotional and intellectual functions. So that treatment with antipsychotics in that area blunts emotional and intellectual manifestations of psychoses or dementias. So an individual with hallucinations or bizarre disorganized thinking may achieve substantial benefit from having a neuroleptic prescribed for that particular indications. The same thing is true of mesocortical. Nigrostriatal, which you're all familiar with as being the pathway in which dopamine is important for Parkinsonism, has very unfortunate consequences for dopaminergic blockade there, which is that you get extrapyramidal motor symptoms, including rigidity, pseudo-Parkinsonism, and tremor. And these tuberoinfundibular pathways primarily relate to go from the hypothalamus to the pituitary gland and regulate endocrine secretion. These increase plasma prolactin levels, which is a really very little significance, but may cause gynecomastia and some of the other manifestations of long-term antipsychotic therapy. And the reason that I'm giving you this background is that I want you to appreciate that the neuroanatomy does have something to do with the relative effects of the drug. And in fact, the drugs themselves have some selective applications to these pathways. The newer generations, the newer antipsychotic agents such as clozapine, in fact, operate primarily on mesolimbic pathways and on mesocortical and have almost no nigrostriatal or tuberoinfundibular action. No one knows why that's true, which is why these drugs are being touted as drugs which have a relative paucity of the bad side effects, including extrapyramidal symptoms and motor rigidity and increased plasma prolactin levels and hormonal abnormalities. So there is actually a pharmacologic reason for prescribing specific drugs. Now, drugs are named on the basis of, neuroleptics are traditionally divided into two categories. There are high-potency neuroleptics and low-potency neuroleptics. The way they receive this label of high-potency versus low-potency neuroleptics pharmacologically is defined by their affinity to the dopamine 2 receptor. But in fact, if you look at a table, you'll see that the dosage equivalency of these drugs, let's see if I can get this on here right. That the reason these are called high-potency neuroleptics is that the milligram per milligram dose that's required to produce the same amount of affinity for the D2 receptor is lower for some drugs and higher for others. As it turns out, the highest potency drugs, the highest potency neuroleptics, and the ones that are the most commonly used in the elderly are in fact haloperidol this is the sort of prima facie example of, this is the drug that's most commonly used in the elderly. The best example and the most typically used example of a low potency neuroleptic, which you can see the milligram equivalency here for every 2 milligrams of haloperidol, I lost it. For every 2 milligrams of haloperidol is equivalent to 100 milligrams of chlorpromazine. So chlorpromazine is a prototypical low potency neuroleptic. High potency neuroleptics are haloperidol. The reason this is important is not just because of their differential blockade of dopamine 2 receptors, but rather because it creates an entirely different constellation of side effects. As it turns out, the low potency neuroleptics, like chlorpromazine, have in fact very powerful, let's just take this. Remember, this is the low potency neuroleptic. I don't know if we're going to be able to see all this. I'll just walk you through it. Chlorpromazine, which is the prototypical example, produces lots of anticholinergic effects, which means dry mouth, blurred vision, sometimes disordered thinking, a lot of sedation, which is why it's given at bedtime, because it helps people sleep, a lot of orthostatic hypotension, which is another reason it's given at bedtime, and which is another reason why it's dangerous to give it to somebody who has a propensity to fall, and has relatively low potential to create acute or chronic extrapyramidal effects. So that's an example of a low potency neuroleptic. High sedation, high orthostatic hypotension, but low incidence of motor problems, dyskinesias, or pseudo-Parkinsonism. On the other end of the spectrum is really haloperidol, and we'll just use these two as examples. It has virtually no anticholinergic effects. It has very little sedating effects. It doesn't matter what time of the day or night you give it. It has very little orthostatic hypotension that's associated with it, but it has major dopaminergic blockade in the nigrostriatal pathways, so that dystonic reactions, extrapyramidal symptoms, motor rigidity, and pseudo-Parkinsonism are common with this drug. So that, like the antidepressants, the way you choose a neuroleptic to prescribe is both on the basis of indications in terms of behavior, but also on the constellation of side effects that best matches the profile of the patient that you have. If you have a patient who's got Parkinsonism, you'd like to stay away from these drugs altogether. But if you had to choose one, you'd choose a low-potency neuroleptic. If your patient's primary disturbance is a sleep-wake disturbance in which about 4 o'clock they start acting out and behaving peculiarly, it may be in your interest to choose a relatively highly sedating, particularly if those episodes are associated with psychotic thinking or delusions or hallucinations. Choice of a low-potency neuroleptic in that person can sometimes blunt that behavior and provide adequate sedation for sleep. If you, in fact, have a patient who acts out during the day or in whom excessive sleepiness is already a problem, you may want to consider a high-potency neuroleptic because they're less likely to produce sedation. Now, let me go through a couple of these slides again. There we go. I'm going to run through some of these because it's not going to... Oh, I wanted to let you be aware of this. If you are going to prescribe a neuroleptic in the site of a nursing home, we already talked about documentation of the indication. There's a second follow-up requirement, is that you have to document, or the nursing staff must document, which behavioral or environmental therapies have been tried prior to institution of the neuroleptic. Next, you have to have a timeline in which you believe that, for which you believe the drugs will be necessary. It's typically recommended that if you're going to do neuroleptic administration, you do it for time periods as brief as 1 to 3 weeks, evaluate the patient's behavior, and then consider gradual dosage decreases if the problem is going to remit. This was unfortunately originally interpreted by regulators of nursing homes to mean that every 6 months people had to try to take patients off their chronic neuroleptic agents. And as many of you are aware, there's a subset of patients who need these agents chronically, not acutely, and who derive great benefit from getting them chronically. And this caused a major stir in community nursing homes when these regulations first came out, because the administrators were constantly trying to keep up with surveyors who were recommending that these drugs had to be discontinued, and physicians were battling with the regulatory agencies. And in fact, this isn't what this really means. I think now everybody's pretty much in sync with the fact that if you document that the indication is present, that appropriate behavioral and environmental therapy has been tried, that the drug itself is effective for that indication, and that behavior worsens when you try to withdraw the drug, you don't need to really write any more after that. Now, we've talked a little bit about this. This is just to give you an idea of the equivalency. Now, so we've decided, we've gone ahead and gone through this part. We've decided that we've developed and implemented a plan. The behavioral objectives were not met. We've decided the behavior is frightening or dangerous to others, and we're going to institute pharmacotherapy. So we've talked about the possibility of starting a drug, and what which I'm going to use the low potency and the high potency neuroleptics as an example. And I'm going to talk about a way in which to titrate these drugs up and to titrate the drugs down. Generally, you'd like to assess a patient's potential risk for drug side effects. And what this usually means is, it's interesting, this is always #1 in risk factors for an adverse drug reaction. A lot of the time there's actual evidence right there in the chart that the patient's had the drug before and has had a bad reaction to it. But in general, because of the anticholinergic, intrinsic alpha blocking activity, and the dopaminergic blockade activity of these drugs, there'll be drug-drug interactions with other drugs that have like therapies. So specifically, anticholinergic drugs like antihistamines, tricyclic antidepressants, and many of the drugs which are used to control urinary incontinence, particularly oxybutynin or flavoxate, all have substantial anticholinergic side effects. And administration of a neuroleptic drug with a high anticholinergic profile, like thioridazine or Mellaril, can sometimes cause what's called a cholinergic crisis, which can be like a mania or a disorganized thinking. The other thing is that each of these drugs, all of the neuroleptics, reduce seizure threshold. So a patient who has a history of prior seizures, you need to be aware that that's a relative contraindication to drug therapy, and they need to be observed for signs of seizure activity. It's not an absolute contraindication to administering the drug. Generally, because of the high potential for orthostatic hypotension on administration of these drugs, it's recommended that you go ahead and do a physical with a standing and supine blood pressures to document orthostasis prior to administration of the drug. And the recommendation here for taking a temperature is because of a rare entity called neuroleptic malignant syndrome, in which patients react acutely to neuroleptics with catastrophically high temperatures and motor manifestations. I have never seen a case of this reported in an older nursing home resident, so I'm not going to really bother with this anymore. This first step is to pick your drug. So we've decided to pick our drug. We have a little old lady who's in our nursing home who's fine all day long. 4 o'clock comes, she has trouble eating dinner, and then she's up hollering and screaming all night thinking that she's seeing her other relatives that have been with her that are all now dead. Your question is, and so we've decided that because of the sedation, because of the agitation that she's causing the other patients at night, that you want a sedating neuroleptic. And you want a neuroleptic which is relatively unlikely to cause her motor rigidity or stiffness, which could cause her function to decline. So you choose thioridazine. And the recommendation is that you begin at very low levels. 10 milligram is the smallest formulation of thioridazine which is available. And that you go ahead and do this on a once-a-day basis, usually at bedtime. If you have the opposite situation, someone whose primary psychotic manifestations or behavioral manifestations are during the day, in whom you do not wish to induce sedation, and in whom nighttime behavior is not a big problem, you may want to choose a high-potency neuroleptic and start with very small doses of haloperidol, usually 0.25 milligrams. These steps of therapy here really indicate weeks. Generally, you need to leave patients on a specific dose for at least a week before you can determine therapeutic efficacy. And you can see that generally, we recommend that you first start with 10 milligrams, then just double the interval. You double the dose by doubling the interval. Then you go successively up to 25 milligrams a day, 50 milligrams a day, 25 milligrams a day, then 50 milligrams a day, and then you can go up to 100 milligrams a day. Now that is roughly 1/3 of the dose which is prescribed commonly for psychotic patients. And the reason for prescribing such small doses, usually the starting dose for a psychotic patient with haloperidol is between 1 milligram to 5 milligrams for a younger person. The reason for starting these drugs at such low doses are twofold. One is that the primary pathway of metabolism for these drugs is oxidative metabolism in the liver. Those are called phase 1 reactions, and they're dramatically decreased with age. So metabolism of oxidatively metabolized drugs, and other examples of which are benzodiazepines and tricyclic antidepressants, is dramatically slowed. So you can count on cutting the dose in half just for that purpose. The second reason for starting off with such slow drugs, such small amounts, is that the end organ cellular mass is decreased, so that the number of target neuronal cells that you wish to hit with this drug is dramatically decreased from younger age. So there are two reasons to decrease the dose of these drugs: failure of metabolism, and two, reduced cellular mass of the target organ. Now, the general ceiling dose which is recommended here is 100 milligrams of thioridazine a day or 2 milligrams of haloperidol a day. And I want to tell you that Wayne Ray's recommendations are extremely conservative in that regard. And I've had a number of very interesting arguments with the clinical pharmacists regarding administration of these drugs. Many patients who exhibit some signs of improvements on neuroleptic agents will require substantially higher doses, particularly at the initiation of therapy. It's not uncommon to use this sort of gradual stepwise approach, but find yourself landing at a dose of haloperidol which is 6 to 10 milligrams a day instead of 2 to 4 milligrams a day. So use these upper limits only as guidelines. They're just suggestions. There are patients who require substantially higher doses, but they're relatively few and farther between. The next step which you'd like to do is decide, are there drug side effects? And what I would like to do is go briefly through with you the major side effects of these drugs and what their known frequency is and what their known treatments are. And as we talked about, the side effect profiles of these drugs are different. One has a propensity to cause motor problems, the other has a propensity to cause orthostatic hypotension. These side effects, the orthostatic hypotensions and the motor problems, are pretty much both dose-related and time-related. I'm going to talk to you about some additional potential side effects of these drugs. The rigidity, bradykinesia, tremor, and festinating gait, the pseudo-Parkinsonism that occurs with neuroleptic therapy. I was really astonished when I was rereading some stuff for this talk. It's listed in the PDR in most of the pharmacology texts and the case series literature that's looked at demented patients as occurring in about 40% of patients who take haloperidol. That's just not true. And I think all of us have clinical experience to show that that's not true. I think when they're prescribed in low doses, this is the most common side effect of haloperidol. It usually will occur somewhere between 5 days and a month after the onset of administration. And it is said that the motor effects are related both to the dosage level and to the cumulative exposure to the drug. So the longer you're on this drug, the more likely you are to develop this manifestation. The mechanism of this is clearly dopaminergic blockade, and the treatment for this is really threefold. The first thing is withdraw the drug. Unfortunately, I think what we often see with patients who develop very profound pseudo-Parkinsonism after the initiation of neuroleptic therapy is patients who had really reduced dopamine levels to begin with. Their nigrostriatal pathways were already severely compromised. We administer the haloperidol and we simply tip them over the edge into frank Parkinsonism. So commonly withdrawal by itself unfortunately does not work. And if you're very fortunate, you'll wait 5 half-lives of these drugs, and since their half-lives are roughly 24 hours for haloperidol, within a week or two the patient may actually be in fact quite better. The caveat to that is that haloperidol is extremely lipophilic, which means that it crosses the blood-brain barrier extremely easily. It binds to fatty tissues. Substantial tissue reserves of this drug are built up, which can last for a very long time. And I have seen pseudo-Parkinsonism remit after 4 to 6 months after brief courses of haloperidol instead of 1 to 2 weeks. So for patients in whom there are persistent symptoms, it is sometimes recommended that you take one of two approaches. One is that you can prescribe an anticholinergic, which can sometimes facilitate motor action, or that you prescribe an actual anti-Parkinsonian drug. I myself prefer not to treat a drug side effect with another drug. But if the progression of the Parkinsonism is such that the function is really limited, I go ahead and do that. This is one of the most bothersome side effects, akathisia. Akathisia is motor restlessness. Gotta go, gotta go, gotta go, gotta go, gotta go, gotta go. Unfortunately, that's very much like the behavior you're treating in the first place frequently. And so that the difficulty with the onset of akathisia is that this motor restlessness and the continual movements or pacing are sometimes mistaken for exacerbation of the underlying behavior, not a drug side effect. So it's particularly important to recognize this as a potential drug side effect, because if you get it, you need to withdraw the drug. It usually happens after you reach steady state levels with the drug, and in the conservative dosage regimen that I just suggested that you take, it might not happen for several weeks. That it really requires an astute observer to determine whether in fact behavior consequences are as a result of the drug therapy or they're in fact a drug side effect. So if you see this kind of behavior develop and somebody's taking neuroleptics, you need to get somebody in to do a primary evaluation. Don't simply call up and ask for an additional PRN order for these drugs, because you may make the situation much worse. Actually, the good thing is that this is much more common in younger patients than it is in older patients. And in fact, this is also both dose-related and time-related. That is, the cumulative exposure to drug predicts the development of akathisia. So short courses at low doses are indicated for most of these complications. If you have, this slide is in the wrong place. We got a bunch of them in the wrong place. You can see I'm writing a grant right now, and I'm sort of zonked out, so I'm a little disorganized. The mechanism of the development of this is actually thought to be a postsynaptic dopaminergic blockade that excites motor neurons, that causes excitatory action in the nigrostriatal pathway instead of that is exaggerated. It's almost like the equivalent of the chorioathetotic movement disorder that you get with excessive L-DOPA administration in the face of Parkinsonism. But in fact, the mechanism is truly unknown. Distinguish it from agitation, withdraw the drug. And some people have had actually remarkable success doing low-dose beta blocker therapy for akathisia. Small doses, 5 to 10 milligrams BID, can sometimes decrease the amplitude of these movements. It's like treating essential tremor with beta blockade. You don't decrease the frequency of the tremor, but you decrease the amplitude of the movements. And that there's a similar finding here with akathisia, that the amplitude of the movements are decreased even though the presence of them is not. This is the most horrible neuroleptic syndrome, the one that everybody fears getting, which is tardive dyskinesia. This is actually, there are differential risks of developing tardive dyskinesia on the basis of the pharmacologic profile of the drug that you take. That is, the high-potency neuroleptic drugs much more commonly cause tardive dyskinesia than the low-potency neuroleptic drugs. So this is another reason to stay away from those drugs if it's at all possible. Tardive dyskinesia is astoundingly common. And in fact, it's said that up to 50% of individuals will develop some form of tardive dyskinesia if they're treated over 5 to 10 years with these drugs. And so many of you who've worked in psych hospitals have seen lots of people walking around with involuntary orofacial movements, tongue sticking out, head gyrating, chorioathetotic movements of the extremities. The difficulty with this is that the onset of it is very gradual. You may not notice the preliminary signs of lip smacking or pursing of lips that occur with it and may continue the drug. It's unclear whether the elderly are at increased risk of this over younger persons. My own personal experience, and I don't like anecdotal experience particularly, but my own personal experience is that I've never seen this induced in an older person in a nursing home who's been on chronic therapy. It really does require therapy for fairly prolonged periods of time to develop this syndrome. Although it is said in the literature that older persons, that is older schizophrenics who are in their 40s and 50s, are at greater risk for developing tardive dyskinesia than schizophrenics who are in their 30s or 40s. And that's probably confounded by duration of drug exposure in those individuals. So it's not clear that age per se confers any risk of developing this particular syndrome. Secondly, the mechanism is thought to be a dopamine hypersensitivity mechanism. Again, it's really unclear. The bad news about tardive dyskinesia is that there is no effective treatment for it. And that in fact, the major treatment is prevention. To use low-dose therapy, to use low-potency agents, to keep the duration of therapy as short as possible. If tardive dyskinesia actually does develop, you should try to withdraw the drug. Remember, but there's a caveat to that as well. If you try to withdraw a neuroleptic agent precipitously, you can develop a drug withdrawal syndrome which mimics the tardive dyskinesia. So acute withdrawal may precipitate a movement disorder which is very like tardive dyskinesia. So in the face of these symptoms, the best thing to do is to reduce drug dosages by 1/3 to 1/2 every week or so until the patient's completely withdrawn from the drug. Do not withdraw it precipitously. You may really exacerbate symptoms and it may confound your ability to determine whether the tardive dyskinesia is in fact going to go away. The other thing you might want to do if a patient develops tardive dyskinesia is you may have somebody who's been cooking along on low-dose Mellaril for a very long period of time and suddenly develops peculiar orofacial movements. You should review the medical record. Remember, we talked about drug-drug interactions with specific drugs. It's very common with a neuroleptic agent when combined with an anticholinergic agent, specifically like over-the-counter antihistamines or cold preparations, to induce sudden onset of a temporary tardive dyskinesia-like syndrome. So the easiest thing for you to do is to review your medication record for things that have been recently added. Unfortunately, that's relatively uncommon. Once you develop tardive dyskinesia, you're often stuck with it. About 50% of people never develop complete resolution of symptoms. And in fact, they may require continuous maintenance of low-dose neuroleptic therapy to make the symptoms as minimal as possible. So once they've got it, they've got it. These are also things that are much more familiar to people taking care of younger patients, these acute dystonic reactions with neuroleptic agents. Acute dystonic reactions are typically talked about in the literature as oculogyrate crises. And these are sudden muscular spasm of the face and neck. And you've probably all seen this if you've administered chlorpromazine or one of the other drugs in the ER, that you'll get sudden neck spasm, eye gyration, peculiar distortion of muscles in the face, head, neck, and trunk. These can be life-threatening, actually, in part because they can cause respiratory compromise. And they're very, very frightening to the patient. I've had a number of young patients when I worked in a rape crisis unit as a medical student, and we would go in to be with the victims as they were undergoing their physical exam to sort of be a patient advocate. And at that point, the patients were typically offered a choice of DES, which was thought to potentially prevent pregnancy. But because DES so commonly caused nausea and vomiting, we would offer the patients chlorpromazine as an antiemetic. Well, it's very startling to see young women who've just recently been raped, who've been through this traumatic event, who then get a drug which causes their neck and head to be completely out of their own control. The good news about this syndrome is that although it can be frightening and it sometimes has disastrous consequences, typically it's easy to make it go away. And I've never seen it in an older person. People say between 1% and 3% of older people who take these drugs develop it. I've never seen it. Its mechanism is completely unknown. All you have to do is withdraw the drug and give an immediate injection of an anticholinergic drug. You can either give diphenhydramine, which is Benadryl, or cogentin, which is benztropine. And generally within a matter of minutes to half an hour or 45 minutes, the syndrome will be completely resolved. It's something that you have to be acutely aware of. You have to know how to handle it in a hurry. It's uncommon. But it's extremely frightening to people who have it. And actually, there's probably a person in this room who's had it, just because the neuroleptics are so commonly used as antiemetics, or people who've seen it. Let me go ahead and turn off the slides. So so we've gone through this, we've chosen the drug, we've titrated it up, we've looked for all the potential complications of neuroleptic therapy. The question is, now you've got a patient who's responded to therapy. They're sleeping better at night, they're acting less psychotic during the day, their behavior somewhat improved. Oh, maybe they're moving a little slower, their appetite may not be as good. What do you do? Should you try to get the patient off the drug? Or should you just leave well enough alone and leave the patient on the drug? Mary, you have any feelings about that?
If you were noticing that kind of change, I might try and titrate it back a little bit and see if you can find some better middle ground. It's going to depend a lot on the patient. Sometimes you can just do a brief course and they'll be okay.
Yeah, and I think that's really the key element is usually duration of therapy is sort of related to the duration of the poor behavior beforehand.
Because a lot of times I would imagine that in the folks who are more demented, you're going to see this escalate when they first get to a new facility.
Exactly.
Maybe it would just get them through an adjustment period, and then they may not need it once they get used to the surroundings and the caregivers.
Yeah, and that may happen. It typically happens when there's an acute stressful event. And that can be a change of location. It can be an acute illness. It's extremely common for demented patients who get admitted to hospitals or ICUs who suffer other physiologic insults to have transitory episodes of psychotic-like behavior. And I think that's the real key, is that Your thinking about the duration of therapy should be directly related to the duration of symptoms prior to initiation of therapy. If it's an acute adjustment reaction, generally therapy can last several weeks or a month and then can be completely discontinued in the same stepwise decrements that you did the increments. But if therapy's been a persistent, difficult, annoying problem, it's been present at home, it's present in the nursing home, it's present wherever that patient is, the likelihood is if you've achieved some stability with minimal decrements in patient function, that you're better off leaving the patient for a period of time on those drugs. And when I say a period of time, what I mean is several months. The third thing that I would like to caution people about use of neuroleptics, there's this widespread movement to just walk through nursing homes and take all patients off of neuroleptics. Do not take your schizophrenic patients off of neuroleptics. I personally have witnessed several cases of patients who had long-standing schizophrenic disorders, had no hallucinations or no thought disorder for many, many years on chronic doses of medications. They had functional decline probably related to medical and or other psychiatric conditions. So there was always a question, is the neuroleptic causing the functional decline? I have never been successful at withdrawing neuroleptic agents for somebody who's needed them for chronic schizophrenic use. And generally, the patients themselves will tell you that. They'll say, don't mess with my medication. You know, I've been to enough places, enough doctors have messed with my medication. Just please leave it alone. This is the way I always am. And every time it gets changed, it takes me months to get straightened out. And I have not heeded the patient's sort of customers always write advice a couple of times and been disastrously sorry that I did so. Because realistically, because of the issue of tissue buildup of these highly lipophilic agents, it can take you literally months to achieve a new steady state. And so I've disrupted somebody's life for several months at a time by trying to do what I thought was the right thing at the right time. So adjust the duration of your therapy according to the duration of the pre-existing behavior. Be satisfied if you have persistent behavior and the therapy results in minimal to no side effects and minimal to no decrease in function. And be careful about discontinuing drugs for people who have chronic schizophrenia. Because they have not had auditory hallucinations or other manifestations of psychosis in years does not mean they're not going to come back. Anybody have any questions?
I guess, when you were talking about the schizophrenic, I realized that some are very difficult to control and can take years. But at the beginning, as you said, people were just being reduced, because that's what they interpreted. Everybody got slashed down, no matter what. I was fortunate in a way that, having worked in psych before, I was assigned to do all of the MDSs. I didn't want to do them myself. And it was really interesting to go back and look and see whether they needed to continue them or not.
What was your experience? I'd be very curious to find out what you found.
I didn't find, of the ones that had some type of medication, you could tell from the history that they had tried to take them off before and it didn't work. So that my recommendation usually was to keep them on, but it was really up to the physician and the pharmacist to decide what they were going to do. But there were many that you could tell by just looking at the record review, they needed to stay on them.
It's interesting, there are now 2 randomized controlled trials. One in Tennessee nursing homes done by Wayne Ray, and the second is a group of Boston nursing homes done by Jerry Avorn. And in both trials, there was a similar intervention. They randomized a set of nursing homes to this intervention and a set of nursing homes to no intervention. The intervention in most cases was twofold. One was a real intense educational program to the staff that were dealing on a one-on-one basis with the patient, so that the staff could recognize how to interpret behavior, how to classify behavior, and how to determine whether behavior would be responsive to a drug or to a behavioral intervention. And then the second part of the intervention was an intervention directed at physicians, giving physicians and nurses a mechanism in which to, a recipe essentially for dosage increases and decreases, and a recommendation that if sedation was the preferred effect of the drug, that there might be other drugs which could more reasonably produce sedation and have fewer side effects. Like chloral hydrate is a common example that's used in nursing home. It's a primary sedative, it has no active metabolites, it's gone after the end of the night, and it has few side effects. Or a short-acting benzodiazepine or a medium-acting benzodiazepine. So the recommendations were pretty parallel in both of those trials. Both of those trials achieved very substantial and and persistent reductions in the prescription of neuroleptics. And Jerry Aborn did a very interesting sub-study in which they actually went and they measured cognitive scores on patients prior to discontinuation of the drug and after discontinuation of drug. And in fact found that there was a subset, roughly 1/3 of patients, who had improved cognition after discontinuing the drug. For the most part, there was no change, but there was definitely a subset of patients who had significant cognitive improvements upon drug discontinuation. The other thing that they noticed was that although the programs were primarily aimed at eliminating neuroleptics, there was a focus on, in Jerry Aborn's program, at discontinuing long-acting benzodiazepines and decreasing the use of benzodiazepines in general. They were totally ineffective in doing that. And that, in fact, what they ended up doing was creating lots of drug substitution. There were many patients who'd been on neuroleptics, like Mellaril used at bedtime for sleep, who now were on short to medium-acting benzodiazepines. And all of you who are familiar with the literature about triazolam know that the very, very short-acting benzos can sometimes cause nightmares and hallucinations in the middle of the night. So that there were many, many drug substitutions in these studies that commonly the behavioral manifestation was still seen as unmanageable and requiring a drug, but the drug had been switched. And the long-term outcome of that, I'm not sure. If, in fact, we do decrease the long-term toxicity of neuroleptics, we're probably better off. If in the long term we can actually institute more effective behavioral management programs, we'd be even better off. But I personally am not against prescribing medium-acting benzodiazepines for people who have behavioral disturbances at night or can't sleep. They're only effective for short periods of time. You can't do them forever because people become tachyphylactic to their effects, so that eventually what you're doing is avoiding withdrawal instead of treating the primary symptom. But I think that the best idea is to try this stepwise approach. Manage it behaviorally, look to see whether the behavior is unmanageable, stick to the guidelines about when these drugs are indicated, not indicated, go up slow, continue the therapy for the duration that you think is appropriate based on the patient's prior behavior, and then give it a couple of tries of downward titration to see if the syndrome is managed. If you've tried a couple of times with a downward titration and found that behavioral symptoms recur and are unmanageable again, you're probably better off for staffing reasons and for other resident satisfaction reasons to go ahead and leave the patient on the drug. Other questions? This is a boiling room. It's really hot in here. Ruth is sitting back there with her jacket on, perfectly comfortable.
I have them turn the air conditioning on. Are you not there? You use the term functional decline. What is your interpretation of that?
Well, I use that term functional decline in the broadest possible sense, in that what I mean. I mean, we could get very specific about what aspect of function that we want to interpret. But to me, that when you're looking at potential side effects from a neuroleptic, you should be gauging both those positive symptoms and the negative symptoms. Functional decline can obviously refer to something that's physical, like decreased ability to walk or decreased participation in exercise programs. But it also should be regarded as a patient who was previously interacting with other residents on a social basis, or was previously participating in activities in the nursing home but is no longer, or who takes much less of an interest in events around him. And so to me, it's really a multidimensional concept that you should, all those things are important. To me, the sort of the social climate of the nursing home is what makes a nursing home a quality nursing home versus a non-quality nursing home. And if the patient is withdrawn, not engaged, not participating, not ambulating, and takes no interest in things going on around them, that's a major functional decline. And you should really be evaluating function in all those dimensions before you're making a decision to either go up or go down on a drug.
Dr. Gerety,
Uh-huh.
would you say that some of these medications increase appetite or suppress appetite more? And of course, if they take too much of it and are out of it most of the time, then they don't eat hardly anything at all. Can I be correct in saying that?
Well, it's really interesting. I've never actually seen any work that looks primarily at appetite. I have seen work that looks at weight loss with these drugs, which is thought to primarily be mediated by sedation.
Yeah.
You're just too gorked out to eat. But there actually is also a substantial literature about weight gain with schizophrenics. Because schizophrenics who have not been participating in sort of regular daily care activities like eating meals will then sometimes get their function regulated, get back on a regular routine, and in fact gain weight once they're on those drugs. As far as specific physiologic effects on appetite, I'm not really aware of that. Although other syndromes that cause hyperprolactinemia can sometimes cause an increased appetite. Like hyperthyroidism can sometimes cause hyperprolactinemia, and that stimulates appetite. I don't know whether it does in these drugs or not.
Do you have any food-drug interaction with the neuroleptic drugs?
Really very few. Very few. It's much more drug-drug interaction. Much more drug-drug interaction. I mean, there are certain drugs which contain lots of tryptophan, like turkey and milk and stuff. But actually those are generally not contraindicated with these drugs. Well, go forth and don't prescribe.